And let's move then into the clinical realm and cover the bases there. Okay, so of course, the presentation has both renal and non-renal aspects. And the renal manifestations of ADPKD involve obviously cystic kidney disease that is obvious by imaging. So there are other cysts that we're going to cover, or cystic kidney diseases, where the cysts are so small you may not see it on imaging studies, but you'll see it on renal pathology. So this is a macrocystic kidney disease, and a varying rates of loss of GFR. Now, the thing to keep in mind is that the macrocystic disease parallels the loss of GFR. That is to say, there is a correlation between kidney size and loss of GFR, such that change in kidney size is even recognized as a reasonable surrogate outcome for some of the studies that have garnered approval for some of the medications that we use, and really tolvaptan for treating ADPKD. Okay, you don't generally, and that increase in size, that increase in kidney size varies based on the underlying genetic mutation, and then probably some patient relevant factors as well. Okay, so not every ADPKD patient is the same. In fact, there's quite a large variation in progression of kidney disease across patients. And even within a family, there's not tight correlation with presumably the same genetic mutation in all members of the same family, although there is a bit of a correlation that patients may have a rate of ESRD or an age of ESRD that's roughly the same within a patient family. That's not always the case, though. Okay. You do have this drop of GFR that happens at a tipping point when you reach a total kidney volume of around 1,500 milliliters, keeping what is normal. So a normal total kidney volume is around 300 milliliters. Each kidney is roughly 150 milliliters in size. So you can see that this is quite a bit larger, right? 5 times the normal total kidney volume that normal individuals have. Okay, so again, you generally have a progressive increase in kidney size without a change in GFR, and then without a meaningful or detectable change in GFR, and then you see this tipping point at around about 1,500 milliliters of total kidney volume. Hypertension happens early, and interestingly, LVH happens early, so even before, in some cases, overt hypertension. So why does that happen? That's not altogether clear. Maybe it involves altered sodium homeostasis, where you have a bit of chronic volume overload even before you manifest hypertension, in which is sufficient to cause remodeling of the myocardium. Okay, but that has been described, LVH and hypertension, which are early. Okay, and that usually precedes the drop in GFR. All right. And the thought is, I don't know if I put this in, and I did not, in pathogenesis, the hypertension seems to be both sodium driven, right? I told you about that relative volume retention that you see, and that may be because hyperenemia could occur by virtue of cysts impinging on the perfusion of segments of that diseased kidney. So the macroscopic cyst may be compressing vessels as they supply the nephron segments throughout the kidney, or the nephron throughout the kidney, and that could result in a hyperenemia. And so we're often using RAS inhibition in particular in patient, or we're using RAS inhibition early, even if they don't have proteinuric renal disease. Okay, flank pain from hemorrhage and infected cyst, or from nephrolithiasis, are features in some patients. Okay, we'll go over the fact that nephrolithiasis seems to occur more commonly than in the general population in ADPKD patients. Okay, I guess that's this next item here. 20 up to 20% of patients with PKD may have nephrolithiasis. And interestingly, this stone type differs from the general population, right? The most common kidney stone in the general population is a calcium oxalate stone, right? By far. And in this case, we're seeing that uric acid stones and calcium oxalate stones occur roughly with similar frequency in patients with ADPKD. So that may arise because there's some alterations in tubular function, one of which is a defect in urinary concentration that may manifest. These patients don't typically, or they don't develop overt diabetes insipidus. You're not going to be thinking of ADPKD as one of the differential diagnoses of diabetes insipidus. But if you were to interrogate tubular function very carefully, you might see that their maximal capacity to concentrate urine is subnormal. Okay. Similarly, there may be alterations in acid handling that may predispose to uric acid stones. Okay. Or even the calcium oxalate stones that are observed. Remember, uric acid stones are at are derived from a overly acidic urine, right? That is the underlying pathogenesis of uric acid stones, aciduria. So again, there may be some disorders of urinary buffer handling, such that urine pHs can be relatively acidic, predisposing to uric acid stones more commonly than in the general kidney stone population. Okay. There's a question about whether, in fact, there is an increased risk of cancer in ADPKD kidneys. In general, we don't think of ADPKD as being a predisposing factor for renal cell carcinoma. However, there's a little bit of controversy around this question, but in general, you should not have to surveil your patients for kidney cancers. But again, there's a little bit of controversy of whether truly there is an increased risk of malignancy, and especially with some of these less common forms of kidney cancers, right? Sarcomatoid lesions. Oh, that's a hard one. Is a pretty rare form of kidney cancer. Typically, these are renal cell carcinomas that are most common. Okay, what are the extrarenal manifestations now? Well, the most significant one that we have to keep in mind is the risk of cerebral aneurysms. Baryaneurysms occur in PKD patients. However, the risk of or the rates of occurrence are still relatively small, right? Only 5% of the PKD population. The estimated rate of PKD of baryaneurysms in PKD patients is around about 5%, and as you get older, that may increase to as much as 20%. Now, remember, ADPKD happens or I guess I didn't make this point or emphasize this point last week, but let me do that now. There is a huge number of mutations that have been described in this immense PKD gene, right? This PKD1 gene, polycystin-1, is a huge gene. And there's a number of genetic mutations that one can see in that gene, some of which are of uncertain significance. So you might even have patients who have mutations in the PKD, in the polycystin-1 gene without any phenotype. And then there's others that have, a variety of mutations throughout the gene. And so that could result in truncating mutations where the transcript is very abnormal, and you can't produce any functional protein, or just very mild alterations in the polycystin-1 protein. So again, you would predict then that you would have a variety of different severity of disease expression in the kidney. Similarly, the severity of disease expression in the cerebral vasculature would be in some way coupled to the underlying genetic mutation. And so there is this family, uh, let's say, familial clustering of berry aneurysms that occur in PKD. So that's why we always ask, well, even if you don't have any CNS symptoms, is there a family history of someone who's developed an intracranial hemorrhage? And if so, we generally prioritize those patients for screening for berry aneurysms. Hepatic cysts are extremely common. In fact, if you look with very sensitive tests like MRIs of the abdomen, you'll see that almost all patients with PKD, ADPKD, have at least small hepatic cysts. But even with using ultrasound, you're going to see macrocystic liver disease in the bulk of patients, 80% of patients. There is somewhat of a gender predilection, and that's actually interesting because we keep that in mind as we're thinking of contraception in some of our patients, our female patients with PKD, because there is an increase in cystic. There's been a described increase in cyst progression in the liver with the use of estrogen. Okay. Pancreatic cysts are also described. Patients with ADPKD, interestingly, have a higher hemoglobin than their, if you have other, so amongst the ESRD population, patients with PKD generally have higher hemoglobins than other patients who have ESRD. Some of that may be just anemia of chronic disease, right? PKD patients are generally healthy, even when they have ESRD, and probably healthier than your diabetic hypertensive patient. And so part of that may simply be because these are healthier patients in general. But the other thought is that similar to the hyperreninemia that may occur through local areas of altered vascular perfusion by the architectural distortion that arises from macrocystic disease, this may also reduce the perfusion and therefore increase EPO production by these interstitial cells in the tubular interstitium that produce EPO, right? So EPO is regulated, or EPO production comes from the kidney, as you know, of course, and that is based on altered oxygen or reduced oxygen sensing by these specialized cells in the tubular interstitium of the kidney. So similarly, again, if you have areas of ischemia, then you might predict an increase in EPO, similar to how you might see it in a patient with OSA or a chronic smoker where oxygen delivery is impaired, right? Okay, so there may be valvular abnormalities. So these individuals, if you are auscultating their heart, you should be paying attention to, any valvular heart disease, or looking for murmurs, in particular mitral valve prolapse. And then they interestingly have an increased risk of GI bleeds from bleeding diverticulosis. They have increase in diverticula of the colon, hernias, bronchiectasis, the cysts of the seminal vesicles, and even cysts in the CNS. These are arachnoid cysts. Okay. Now, again, the most relevant one here is cerebral aneurysm. So when you're asking in your review systems of a PKD patient, you should certainly be inquiring about any CNS symptoms, double vision, headaches that are not explained, and anything that may be consistent with that a potential aneurysm. You should probably be asking about as well any symptoms of shortness of breath or palpitations from mitral valve disease. You should be asking about any kind of hematochezia. These are some of the ones that are most significant. They have hepatic cysts, and some can have early satiety from the hepatic cysts, but generally don't have signs and symptoms of cirrhosis. Okay. Synthetic function is preserved with the liver disease. of PKD. You sometimes have massive replacement of the liver by cysts, but generally these patients don't develop portal hypertension or increases in bilirubin or coagulopathy. Now, portal hypertension can happen in these patients, and usually that is because the cysts are simply pushing on the portal vessels, and it's a anatomic portal hypertension as opposed to the progressive fibrosis that you're most accustomed with. Okay, so diagnosis would generally involve, just characteristic uh, imaging studies. Okay, many patients with PKD are diagnosed through an incidental finding of a CT scan, right? A CT scan that's done for belly pain or flank pain, and then they see huge or multicystic kidney disease. And so most patients do not undergo genetic testing in order to make the diagnosis. It's typically based on the imaging features, characteristic imaging features. Okay. And often there is the concomitant liver disease that's present, cystic liver disease that really seals the deal. Yes, this is most likely ADPKD. Okay. Now, they, of course, could have, family history or not have a positive family history. You can have a de novo mutation that occurs in someone such that they don't have a positive family history. Okay. Um, and there is no sort of universally understood criteria for diagnosing ADPKD in patients without a known family history of polycystic kidney disease. We just sort of this is one of those things where you just sort of call it when you see it, even if you don't have a standardized criteria for making a diagnosis of PKD in the absence of a positive family history. Now, we do have some criteria that are used to diagnose PKD in patients who do have a family history. And this is often leveraged in identifying patients or potential kidney donors. So if you have a patient who has ESRD from PKD, they are often looking to their family members for living donors. And you do not want to take a kidney from a younger family member who may have PKD themselves, of course. And so there is an imaging criteria that is used to make the diagnosis of PKD in a patient who belongs to a family that has a known history of ADPKD. Okay. So these criteria are again for the individual who has a positive family history. All right, so based on ultrasound criteria that have been published, if you're a young patient anywhere from 0 to 15 years of age, we have less certainty about whether or not that individual has PKD. And so we generally would not rely on only imaging findings to make a presumptive diagnosis or an exclusion of PKD in patients this young. However, that being said, you can sometimes see a single cyst in a young patient, and then that would be highly suggestive of an underlying PKD mutation that has just not had time to manifest in any other meaningful way. So a single cyst in a patient that's less than 15 years of age with a positive family history of PKD would be highly suggestive, but we don't have really firm grasp of what is the sensitivity and specificity of that finding. You'll notice also still in this relatively young age group, our sensitivity is not perfect, right? You want if there's something high risk like taking a kidney from a potential donor, you want a high sensitivity for diagnosing ADPKD. And so in these younger patients who are in the 15 to 29 year range, you might more you might rely on genetic testing uh, more confidently. Okay, you probably would not just use imaging studies to say, yeah, I'm quite certain that you don't have ADPKD because the sensitivity is roughly 80%, which is not enough for something that might be that high stakes. Okay, so you may have a young individual, if you have greater than or equal to 3 total cysts. Okay, that means 1 in 1 kidney and 2 in the other. That would be considered 3 or more in both kidneys. That would have a sensitivity for ADPKD of 80%, but be highly specific, right? Remember, this specificity is also with the known uh, history of a family history of ADPKD, okay? Now, as we get to some of these older ages and the finding of bilateral kidney cysts, we then have more and more sensitivity and specificity for this. Again, this could be used in this scenario to make decisions regarding kidney donor candidacy. 40 to 59, you can see that I don't need quite as many cysts in order to have reasonable specificity. But if I want to maximize, again, sensitivity, more cysts are generally going to be more sensitive. Okay, so as we get to older age, just because as we age, we have more cysts that are found in the general population, you can see that the threshold for making the presumptive diagnosis of PKD has increased as you get older. Okay, that's just because the finding of renal cysts is more common as we age, even if you don't have a PKD history. Okay, there are also some published screening guidelines for MRI imaging, and you can see that this is a much more sensitive study for finding cysts. CT scans are also quite good, but that is not in the published literature, a published sensitivity and specificity. In this MRI-based study, you can see that if you have greater than 10 cysts visualized on MRI imaging, then you are really approaching a sensitivity and specificity that is quite reliable, 100%. Okay? Genetic testing is available and is being relied upon more and more, okay? Now, know that you could have PKD without mutations in PKD 1 or 2. We've gone over the fact that there's other mutations that may underpin the ADPKD, right? So we went over that last week. The differential diagnosis of PKD, right? Alternate causes of cystic kidney disease should be in your mind, because you will get referrals as a nephrologist, practicing nephrologist, for kidney cysts. Okay, many of those I turf over to urology when they're really simple questions. However, sometimes it's, when you see somebody with multiple cysts, it really gets to be challenging to make a firm diagnosis of whether someone has ADPKD or other kidney cysts. So there are other kidney cystic diseases to be aware of. Certainly the most common is just a simple acquired cyst, okay? And again, I get a lot of consults, e-consults at Parkland for these that I always have to kind of turf over to urology. And I've told you that as you get older, you get more commonly the observation of simple cysts. You can see here's one estimate at 25% in patients that are over the age of 60. Acquired cystic kidney disease refers to patients who are on dialysis who can develop actually quite impressive cystic kidney disease, where it does look like an ADPKD kidney. The difference, however, meaning they're diffusely replaced by kidney cysts. The difference, however, is that these kidneys are not large like ADPKD kidneys. These generally are sometimes small or normal in size. We don't know why patients who are on dialysis for many years develop this predisposition to form diffuse replacement of their kidneys by cysts, but it is a well-described phenomenon. It happens quite commonly in patients who reach greater than 10 years of dialysis vintage. Okay, these cysts tend to shrink in size after transplant. And these, unlike the ADPKD kidneys, do have a detectable increase in the rates of renal cell carcinoma. You can see that one estimate is around 5% over a 10-year period. Okay? So when you have a patient, that's relevant when you're working up patients for transplant. Again, acquired cystic kidney disease is common in patients with prolonged dialysis vintage. You would want to consider surveillance in a transplant patient who has a history of acquired cystic kidney disease for malignant transformation of those kidney cysts and the development of renal cell carcinoma later. Okay? Um, Autosomal recessive polycystic kidney disease. We'll talk about in little more detail in a separate section, so I won't go over that in great detail here, except to say that, sometimes it's not so obvious. We think of ARPKD as being primarily a disease that our pediatric colleagues see, but there are well-described instances in which ARPKD presents in adulthood. And we'll go over some of those varied presentations as we segue over to ARPKD. Okay? These would have, as you're thinking of this differential diagnosis, you're thinking about, acquired cystic kidney disease in the patients with prolonged dialysis vintage. You're thinking about ARPKD in patients that have negative family histories, right? A recessive condition would generally have a negative family history unless you have consanguinity in that family. And then these individuals would also have evidence often of liver disease, not just the anatomic liver disease, but actually evidence of portal hypertension, for instance. Again, we'll talk about that as in just a few minutes. Okay, so these individuals actually develop portal hypertension, and you can do genetic testing for both ADPKD as well as ARPKD. Tuberous sclerosis. We have a couple of these actually in our PKD population, and they're pretty interesting. This is another multicystic disease, and um, um, you should know it. It is an autosomal dominant condition. Interestingly, this gene is adjacent to the polycystin 1 gene. And so it has patients with a mutation or a mutation that spans both genes have been described and have a particularly severe phenotype. These individuals have a variety of manifestations. The tuberous sclerosis gene is a tumor suppressor gene. So these are other examples of disordered cell division, right? But they're not overtly cancerous. These are all sort of under the umbrella term of hamartomas, so uncontrolled cell division, but that is not a malignant transformation that results in metastases. So these angiomyolipomas are examples of hamartomas. They're mixes of blood vessel, disordered cell division, blood vessels, fat, and muscle. These angiofibromas are another form of that. You can have abnormalities in skin pigmentation. These fibromas under the nail is another description. The hypomelanotic macules are this hypopigmentation that you can see on the skin. You can have these retinal growths as well, so that you have to have these patients see ophthalmology. You can also develop these non-malignant tumors in the brain as well. These are sort of described as looking like tubers or sort of the potato-like lesions on imaging. These subependymal nodules are other forms of hamartomas. That's what this is. Okay, the rhabdomyoma, another form. And then you can have these mixes of blood vessels and smooth muscle that can happen even in the lung. Okay. These are major features. Minor features include some dental abnormalities. You can see these dental pits, abnormalities of gingival growths, and I've listed them here for you. Okay. Von Hippel-Lindau is another disease that can present with kidney cysts. Okay, this is an autosomal dominant condition, also arising from a mutation in a tumor suppressor gene, as you know. Now, these are commonly overtly cancerous. So there are some non-cancerous angiomas, but certainly you can develop carcinomas of the kidney. You can have hemangioblastomas that happen in the CNS, pheochromocytomas, which are not malignant but still altered, arise from this mutation in a tumor suppressor gene. You can have pancreatic cysts and middle ear abnormalities as well. Okay, so that's von Hippel-Lindau. ADPKD. So just bringing it back to the clinic. Remember again, what you're going to get is a patient who has often, as a referral, multiple cysts. You're going to have to know these general syndromes so that your mind is attuned to looking for these physical exam findings, as well as family history when it's an autosomal dominant condition. So that's why it's important for you. You might think that this is all like step one stuff. Why do I need to know this? You do get these consults, and you're going to have to at least touch upon these conceptually as you think about other possibilities when it's not clear that this is just a straightforward ADPKD. Okay. Interestingly, there are patients that may have just pure liver cysts without noticeable kidney cysts, or these individuals would have just dominance of liver cysts with only a few liver cysts. And that has a name. It's called autosomal dominant polycystic liver disease. So another interesting phenotype that may cross your path, okay? Because again, they often will have a few kidney cysts, all right? There are other rare cystic kidney disease syndromes. We went over one of them when we talked about the one of the forms of tubulopathies that can arise from a mutation in the gamma subunit of the sodium potassium ATPase, or the regulator of that gamma subunit, which is this HNF1 beta. I won't go back to the tubular transport map, but we talked about, again, a tubulopathy that looks like a Bartter syndrome, that can also sort of overlap with a Gittleman syndrome phenotype. So that would be another example of an individual who can present with cystic kidney disease that has also MODY, or maturity onset diabetes of the young, as well as some tubulopathies. Okay, so let's move on to prognostication. We have the Mayo Clinic classification, which we are using for prognostication by and large. Remember, I told you if there's a correlation between kidney size and loss of GFR, it makes sense that we can use measurements of kidney size to make clinical decisions for our patients. So this is an available clinical tool for anyone. It's an internet-based tool where you can plug in either CT or MRI imaging, and even if you have the access to special ultrasound imaging, so there's a specific sort of 3D imaging that you can use to get more precise estimates of total kidney volume, even with ultrasound. In general, however, we're using CT scans and MRIs to measure kidney size and actually plug it into this Mayo Clinic classification calculator that's online, and then to categorize your patients as lower risk patients. So those are considered 1A, 1B, and 1C patients. Or I say 1A and 1B, okay? Those are considered your lower risk patients. And then your higher risk patients are these 1Ds and 1Es. These are basically patients who are young but have large kidney size, right? If you develop massive nephromegaly, even though you're young, you're going to fall into these 1D and 1E categories. If on the other side, you have big kidneys, but you're in your 70s, you're going to be in this more 1A, 1B category, right? So it's just how fast are your kidneys growing? And this intermediate 1C is where you kind of need to straddle to make sort of a nuanced decision about whether or not to use tolvaptan. The reason to Mayo risk classify patients is to provide prognostication counseling to your patients, as well as to make a decision on whether the risk benefits are in favor of using tolvaptan. We reserve tolvaptan for the 1Ds, 1E patients, and then some of the 1Cs. You don't pull out tolvaptan for 1A and 1B patients, okay? Pro-PKD score is another risk score that's out there. In general, you can't use it very commonly because most patients we don't do genetic testing on. So you need to know that in order to inform the pro-PKD score. This too is available, by the way, online. However, knowing the pro-PKD score is still important, not only because if you happen to have the mutation or the genetic information, you can still use it. But it also gives you some interesting other uh, facets of prognostication in PKD. Male patients generally have worse prognosis. Patients who have early onset hypertension have worse prognosis. And this has, been described for a long time, but it's not real clear, how it's obvious why having a quote unquote urologic event and having them commonly or happen early is also a risk factor that carries worse prognosis. So this is part of the pro-PKD score. So you'll elicit from your patient, did you have a cyst infection or an admission for severe cyst pain or gross hematuria at a young age? If so, that would be a point on the pro-PKD score, a predictor of worse prognosis. Now, this is important to use, for instance, if you have a 1C patient. So if you have a 1C patient and you're weighing the risk benefits of using tolvaptan, you might factor in some of these things. How early did they develop hypertension? When did they have their first urologic event, if they had one, in order to, again, add additional dimensions to the total kidney volume in prognosticating your patient. Another way that you should, make a decision on, particularly on those 1C patients, is just look at their trajectory of GFR decline. If they showed you that their GFR is declining fast and you measured them to be a 1C patient, then you obviously should target those patients for tolvaptan. So what might one use as a threshold for fast progression? You might use this GFR decline of greater than 3 mils per minute per year. Putting that into perspective of your rate of decline of GFR, or maybe I'll say my rate of decline of GFR, if you're not quite 35 yet, we're losing about a half cc per year. If you're, the normal age-related decline in GFR. If you have a big kidney at a young age, so maybe you don't have such, you don't have a CT scan, but you have an ultrasound and you see, huge kidneys in a young patient, that itself may be enough to sort of put them in this high risk category and be thinking about tolvaptan. Family history has some correlation with prognosis, but it's not perfect. So we often ask in our history taking in a new PKD patient, do you have other members of your family who have developed ESRD? And if so, what was their age when they developed ESRD? Yes, I have a brother who has ESRD in his 40s. You would say, oh, you seem to be in the higher risk category. But again, that does not trump a total kidney volume. If you have a reassuring total kidney volume, even if you have another sort of family member with early onset ESRD, the total kidney volume is the more reliable tool to prognosticate with. Okay? All right. And I guess I should say, I'm surprised I haven't said this explicitly under prognosis. Yeah, I guess I haven't. But we estimate that the rates of ESRD and PKD, ADPKD, is roughly 50%. Okay, so it's not a guarantee that you're going to develop ESRD. So we don't know that number with precision because we're probably underdiagnosing ADPKD. So there's plenty of patients who are probably going under the radar, right? Who never had CT imaging to make the diagnosis. But we estimate it at roughly 50% of patients who are going to develop ESRD. Okay. So how do we manage these patients once we've defined prognosis? ACE and ARB, I told you, is usually a go-to medicine, even if you're not proteinuric, because we think that the hypertension is driven by an increase in renin and aldosterone as a result. Okay? If you have an individual who has early yeah, I should have put this in here as well. Please add this as a modifier. Tight blood pressure control is probably a reasonable target for patients who have preserved GFR. Okay, I think I put this in your hypertension section of your field guide, and you'll probably notice it in some of the note templates that you may be using, but targeting a blood pressure less than 120/70 may be reasonable when you have preserved GFR. That's based on the HALT PKD study. You don't need to target less than 110 if you have CKD4. Okay, this is for early stage CKD, early stage ADPKD, essentially with preserved GFR. That seems to reduce the rate of progression in kidney size based on a randomized controlled trial. Okay. So think about that in your early stage ADPKD. Tolvaptan, I mentioned, is one to consider. Now, you need to know some of the GFR cutoffs. We generally reserve it for patients whose GFR is greater than 25 mils per minute per 1.73 meters squared. And then I told you again, if you can prognosticate and find them to be a high-risk patient based on trend in GFR or kidney size, those are patients that you would target for tolvaptan, right? Your 1D and 1Es, and then some of your 1Cs, okay? Or if you had a pro-PKD score greater than 6. You consider caffeine restriction and the limitation of other phosphodiesterase inhibitors. We don't use, we don't use, blanking on the COPD, theophylline, right, in COPD anymore, but pentoxifylline theoretically would be a phosphodiesterase inhibitor as well that you might consider limiting these, and then caffeine might also reduce, might be caffeine restriction may also be a reasonable consideration. However, I don't get dogmatic about this. There is no good data that shows that caffeine restriction is a worthwhile intervention. If somebody has to have their coffee to function, I say, okay, fine. All right. Water loading is also something we often counsel, but keep in mind that too is not based on evidence. Some people have even tried to use urine-specific gravity, targeting a lower urine-specific gravity to see if you can make a change on progression of kidney size, and essentially it was not helpful. Okay, so I don't get dogmatic about trying to drink a lot, especially when you're having volume control issues. It wouldn't make sense at all. Okay. Cyst infection is something that you're tested on, that shows up on tests. You got to know which drugs actually have good cyst penetration, and that would be your fluoroquinolones and your Bactrim. We don't use much chloramphenicol, but that does also have good cyst penetration. How do we manage the cerebral aneurysm dimension of ADPKD? We do screening tests, either with MRA or even CT angiogram. You don't need contrast with the MRA, so that is often the study of choice that we're selecting. And whether or not to screen everyone, okay, screen everyone or only those with risk factors is a art of medicine decision. And some have espoused, just limiting screening tests to individuals who have that positive family history of a aneurysm or a hemorrhage, or if you're planning something that like a big surgery, if you're an airline pilot and you had a intracranial hemorrhage and you're going to take, 200 people down with you, those would be things that you would think about screening people for, the Barry aneurysms. Or you might do, everyone deserves it at least once. Okay, you can sort of make an argument for both. All right. Whether to re-image is kind of weak data, but some might say, okay, go ahead and re-image in another 5 years if you're an airline pilot, right? But I think if you have no family history and none of these other sort of modifying considerations, if you've done it once, you're pretty much done. I don't sort of do it, for every 5 years. And if you have an aneurysm, basically you're going to farm this out to neurosurgery. You just generally are not driving, the repeat imaging, right? You're just going to get them over to neurosurgery and then they're going to follow up with them. Okay. And then neurosurgery has their criteria for actually preemptively coiling some of these aneurysms. I won't go over that. Renal replacement therapy is notable for a good prognosis. These patients have, a prognosis that is much better than the classic sort of diabetic and hypertensive patient. And you can do PD in these patients, even if they have these big kidneys, unless they're really massive. And in those cases, you're probably considering even nephrectomy for patients who might have other sort of complications of their PKD. Some have even developed malnutrition because the huge kidneys are impinging on their ability to eat. Okay. Um, and I guess that's it for ADPKD. Okay. Let's say some words now about ARPKD. Any questions before we move on to ARPKD? Okay. All right. Let's talk about this. As I mentioned, this is not solely a disease of pediatric nephrologists. We do need to know about these. The gene involved in this condition is the PKHD1, and that codes for this protein fibrocystin, and that also is a ciliary protein. Sort of highlighting this theme of pathogenesis of cystic disease. Okay. These individuals also have variable course, and similar to our prior discussion, variability in genetics translates to variability in clinical course. Okay, and so the same is true for ARPKD. Now, these individuals, unlike the others, do have complications of liver disease, and that can often be a dominant feature, right, of their presentation. Okay, they have, Eric, actually periportal fibrosis with portal hypertension. And these individuals also may have these dilations of the bile duct, predisposing them to that stasis-associated cholangitis. Okay. So they do have hepatic complications. They are following with hepatologists. LFTs are normal, but this fibrotic liver disease does result primarily in complications like the aforementioned portal hypertension and and cholangitis. Okay. The renal manifestations. Okay. These kidneys are big early on and then start to kind of get small over time. So interestingly, what you may find in a late presentation of ARPKD is more echogenic kidneys with cysts that may not be obvious on kind of renal ultrasound imaging. You might see more just kind of a echogenic kidney, and then primarily they present with signs and symptoms of liver disease. Okay, so renal function can, on the other side, a renal dysfunction, I'll say, on the other side of the coin, can be manifest even in the early infancy. So that's another way that these patients can present with terminal renal failure, essentially in the very young patient, or reasonably preserved GFR with a presentation of primarily liver disease in sort of the 20 and 30-year-old. Okay, those are sort of the ends of the spectrum of how these ARPKD patients may manifest. Okay, so these individuals could have tubular transport defects, similar to how we reviewed that phenomenon in ADPKD. These individuals can have recurrent UTIs, and these patients can have early onset hypertension. So here is where I'm sort of re-emphasizing the variety of presentations. So I'll just put it into these boxes. A early onset presentation that happens in infancy at less than 1 age, in early or sort of in childhood, let's say, is a second box, and then in the young adult is the next sort of presenting age group. Earlier presentations, again, with more severe renal disease, and later presentation with more liver disease, right? They may show up as ascites, and then the diagnosis actually reveal itself as ARPKD. Okay. Diagnosis, again, is based on imaging. There is genetic testing that's available. And here are some of the imaging findings that you may encounter. Again, echogenic kidneys may be the phenotype, as opposed to with these small cysts that may only be visible on, CT or even MRI imaging. Okay. And then just primarily an echogenic kidney, and then liver showing signs of hepatomegaly, echogenicity, and then sometimes these biliary ductal dilatations. Okay. Ductal dilatations. All right. Prognosis is often, pretty poor, actually. But these patients are, again, often succumbing to some of the complications of liver disease. And then obviously, that dialysis is not a perfect solution, so survival is not great in these patients. It's certainly a more severe disease than ADPKD.
Patient survival or kidney survival?
This would be I don't know what I'm trying to say here. Yeah, I guess this would be patient survival. Yeah, yeah. Yeah, yeah. The question from the group is, would you be considering dual organ transplant in patients like this? And the answer is yes. Yeah. Liver disease and kidney disease. Yep. All right. And just let me put a point on that. ADPKD, it is rare, though not never, that we do dual organ transplants in ADPKD. So remember, ADPKD has huge livers sometimes, but generally has preserved synthetic function and no portal hypertension. If you have a patient who has portal hypertension, and again, that's usually anatomically induced because of impingement by the cystic liver, then you consider combined liver kidney transplant, and even in ADPKD. So it's been done, and it's been done at our institution, but it's pretty rare. Okay? Unlike ARPKD, where you're going to have, severe liver complications commonly. Okay. Let's go a little further. Let's do medullary sponge kidney. Shouldn't take long to do that. So medullary sponge kidney is kind of a little bit of a mysterious condition. Even some of the definitions have sort of varied, or some of the diagnostic features have varied over time. And it's been less, we used to do more IVPs, and medullary sponge kidney was a diagnosis that we would use IVPs to make. So, we don't do those anymore. And so, again, medullary sponge kidney has kind of been a more, I would say, let's call it a spongy diagnosis or squishy diagnosis that sometimes you can't confidently make. Okay. So what is the pathogenesis of a medullary sponge kidney? What are we actually seeing? Well, these individuals have these collecting ducts, which are abnormal, they're very dilated compared to the normal collecting duct. Okay, and so you can actually see it on ureteroscopy. You look with a ureteroscope, right? A urologist who's doing a stone extraction with a ureteroscopy can go and make the diagnosis of medullary sponge kidney incidentally. when they're taking care of a stone, they'll say, oh, it looks like the papilla that is draining into this calyx has these dilated collecting ducts that they can see on ureteroscopy, okay? So that is one way it can be made, ureteroscopy, where you see these dilated collecting ducts, okay? Or you can see it sometimes on a contrast CT scan. Sometimes they'll say this delayed nephrogram, where you'll see the classic, we call it paintbrush feature. It looks like the actual contrast persists in the calyx, or in the papilla, I should say, and it shows up as this kind of paintbrush feature on either IVP or a contrast CT scan. Okay, and those are just contrast that's pooling in that dilated collecting duct. Okay, so there are others who have espoused looking for, particular histologic features on kidney biopsy to be conclusively diagnosing medullary sponge kidney. So I would say, again, there's a bit of, again, squishiness to the diagnosis. There's not a genetic test for it either. We don't know that this is clearly a disease of a genetic disease. It seems to be a disease that occurs during development and not clearly inherited. Okay. This is associated with an increased risk of kidney stones. So I would say that's where we are tentatively making this diagnosis of medullary sponge kidney most commonly in a kidney stone former. Again, we see these ectatic tubules. These can develop these can also have tubular transport defects that may include an incomplete distal RTA. These patients may have hypercalciuria more commonly than the general population. They may have low urinary citrate. They may have high urinary oxalates. The type of kidney stone, it used to be the case that it was thought that, did I put this in here? Yeah. Maybe add this to your field guide. It used to be the case that people thought that medullary sponge kidney, because of this association with incomplete RTA, was more associated with calcium phosphate stones. But if you look at some modern published cohorts of medullary sponge kidney, it looks like calcium oxalate stones are the more common stone type in medullary sponge kidney, similar to the general population. Okay. Okay, so the presentation, again, most of these patients are asymptomatic. However, some of these patients come to presentation because of the nephrolithiasis history. And I told you about the findings, the imaging findings, this paintbrush feature. And then you can have the ureteroscopy finding of this billowy appearance. And then these patients may even have hematuria without overt kidney stones. Some have described a correlation with recurrent UTIs. That's, I guess, I would say a questionable association. And then we've talked about some of the tubular transport defects that might be a feature as well. Okay. Any questions about medullary sponge kidney?